السلام عليكم، معكم دكتور أحمد الغيش Assistant Lecturer Periodontology Department. We will start part 2 of the periodontal charting, starting with the page number 3, the periodontal record. Before periodontal record, we should recognize this figure or this picture. This is the upper piece, and this is the lower piece. This is the facial surface of the upper teeth. This is the palatal surface of the upper teeth. This is the facial surface or labial surface of the lower teeth. This is the lingual surface of the lower teeth. Here is the propping one. Propping one meaning the periodontal pocket depth at visit number 1, propping 2 visit number 2, propping 3 visit number 3, and it is the mobility 1, mobility 2, mobility 3, and this is date. The palatal or propping pocket depths in the palatal side 1, 2, 3 as before. The lower arch, this is the periodontal pocket depths and visit 1, visit 2, visit 3, mobility 1, mobility 2, mobility 3, and at the lingual portion. Okay. Before we start, we should revise some terms. Number 1, the pocket depth. The pocket depth is the distance from the free gingival margin to the base of the pocket. The attachment loss is the distance from the CEG to the base of the pocket. We start periodontal record by Williams probe. I think you know Williams probe from diagnosis. Williams probe is degreed from 1 to 10 as sequence 1, 2, 3, 4, 6, 7, 8, 9, 10, inserted with the long axis of the tooth and record 3 readings from each surface, 6 reading per tooth. This photo illustrates the difference between healthy tissue and the periodontal disease. This is the periodontal pocket or the degreed periodontal pocket. That is the healthy gums and the healthy bone level as shown. When you insert the periodontal pocket, it will travel to stop here. The stoppage here is the beginning of the periodontal attachment fibers or the junctional epithelium here. So in the healthy tissue, the probe will be travels to the end of the pocket or the end of the gingival sulcus or gingival groove till this point because we have a healthy junctional epithelium and a healthy bone level. But when periodontal disease occurs and the plaque and the tartar accumulate around the neck of the tooth, here is the periodontal pocket depth or periodontal pocket. So the probe will be traveled in this periodontal pocket, getting the periodontal pocket depth from here, from the free gingival margin to the base of the pocket, because we have here a periodontal pocket and the breakage of this junction occur. We will see a video that will treat all of this. Please concentrate.
Periodontal disease begins in the gingival sulcus, a cuff of soft tissue around the necks of the teeth, where they emerge through the gums. Healthy gingiva are pink in color, and the sulcus depth ranges from 0 to 3 millimeters, measured from the tip of the gingival margin to the base of the sulcus. The attachment fibers connecting the gums to the teeth and the teeth to the bone are intact. The gums are resilient and neither bleed nor hurt when being probed. During meals, food debris accumulates in the sulcus. When mixed with mouth bacteria and proteins from saliva, plaque and less obvious biofilm are formed. Both are harmful to teeth and periodontal structures. Left in place on the teeth, bacterial plaque and biofilm begin to mineralize, forming hardened deposits called calculus, which can only be removed with dental instruments. In response to the increased bacteria adjacent to the soft gingiva, the body sends immune cells and healing cells to the area by way of the circulation. The increased blood flow to the gingiva produces red, enlarged, and tender gum tissues, a reversible condition known as gingivitis, in which the periodontal attachment fibers remain intact. Continuous exposure to acids and enzymes from plaque bacteria and the body's immune response to them eventually causes the periodontal attachment to be lost, an irreversible condition known as periodontitis. The sulcus depth increases to the point where the patient can no longer effectively remove plaque, leading to the destruction of tooth supporting bone. Smoking impairs blood flow and can significantly interfere with a patient's ability to fight the bacterial infection. Other factors may be involved.
You see in the video the sequence from the healthy to a periodontal disease. Okay, so how we will draw this in the chart. This is the Williams probe, and this is the probing as we told you before. We record 3 readings from each surface and 6 readings from for the tooth. 3 readings on each surface at the mesial and the middle and the distal. At the middle recording, we take the mean, the most depth here, and the same at the lingual side. The mobility test, we record the mobility. We record the mobility by 2 instruments, or the back of the 2 instruments, or 1 instrument and the index finger. We have 4 degrees of mobility. Number 1 is the normal mobility. Okay. Number 2, it is a mobility less than 1 millimeter. Mobility degree 2, mobility degree 3, it is more than 1 millimeter. Degree mobility degree 3 or grade 3, it mobility grade 3 is obvious mobility, and the tooth moves in different direction, oculingual and epicocylindrical. When we see the patient mouse, we will see this picture. You see the tooth and the papilla around the tooth, or between the tooth and the gingival margin. Then we see the pink gingiva. Then we see the mucogingival line and of the vestibular mucosa, or the lingual or the labial mucosa. So the free gingival margin, we draw it according to its position. For example, here we found it at the CEJ. Here we have a recession. We just draw the patient mouse. Here the clinical crown is short because of the gingival enlargement. As we see, we draw as we see the patient. We draw the patient. The mucogingival line according to its position, as we know that the mucogingival line or the amount of attached gingiva is different from patient to patient. So we will draw it in at a scalloping margin, just like this, scalloping margin, just like this. The mucogingival line is scalloped in the anterior area and then faint or straight in the posterior area. It's scalloped in the anterior and faint in the posterior. The same thing at the labial or the lower arch and the lingual or the lower arch. But in the palate, we don't have a mucogingival line because all of the palate is a keratinized mucosa. How we calculate the attachment loss? In the normal position, we don't have attachment loss because of the pocket depth is from 1 to 3 millimeter. It is the depth of the gingival groove. But when we have abnormal position in the precision, for example, this is the tooth and this is the gingiva and this is the insertion of the periodontal depth. When we insert the periodontal pocket from the CEJ, from the gingival margin to the base of the pocket, it is the pocket depth. And here is the CEJ. The amount of the periodontal destruction or the attachment loss is calculated from the CEJ to the base of the pocket because the ordinary attachment was here or the junctional epithelium was here. As we see in the video, the inflammation start to detach the fibers from here to reaching to the base of the pocket. So when we insert the periodontal probe from here to here, it is the pocket depth. But the area from the CEJ to the base of the pocket, it is the attachment loss. And this is the top of the pocket. So that when we have a periodontal pocket depth, for example, measuring 6, the normal pocket here or uh, the area from the CEJ to the top of the pocket, the normal situation is by 2 millimeters. So the attachment loss will be the pocket depth minus the amount of the top of the pocket equals attachment loss. So in the situation of the pocket depth measuring 6, we will minus 2, so the attachment loss here is 4. This is for the pocket. So we found here the pocket depth measuring at the mesial line angle by 6 and at the middle by 5 and at the line angle as a 4 and the other tooth is 5, 5, 4 and this lateral is 7, 6, 5. So we will here as the area of the 7, so we will be 7 minus 2 equals 5, so the attachment loss here is a 5 and the attachment loss here is 4 and the attachment loss here is 3. This is different in the precision When we have a case of recession, just like this photo, here we have, this is the CEG. This is the starting of the attachment loss. And this is the free gingival margin. So when we insert the pocket here, this is the pocket tip. So when you insert the pocket here, from here it will stop nearly this point, so it is the pocket depth. But the attachment loss here is equals the pocket depth plus the recession. So in the periodontal pocket depth or the pocket depth, we will minus the normal position, but in the recession we will adding this pocket. As this case, when we see this case is a case of recession, this is the tooth and this is the CEG. And when we insert the periodontal probe here, this is the base of the pocket by the black line. This is the gingival margin, and this is the CEG. When we measure the amount of or the distance from the CEG to the base of the pocket, it is the attachment loss. When we measure this blue line from the free gingival margin to the base of the pocket, it is the pocket depth. The area from the CEG to the free gingival margin, it is the area of recession. So that when your pocket depth is 3 millimeters and the recession is 4 millimeters, so that the attachment loss in this case is 7 millimeters, and this case diagnosis as a periodontitis. How we draw the recession in this figure? We just draw the patient mouth. Just to draw the patient mouth. We will, by the black line or the black pencil, we will the black pen. We will move to this area of recession and draw it like this. Okay, and here we measure the periodontal pocket depth was 2 to 3. But we need to know the attachment loss. So the amount of recession to get the attachment loss equals the amount of recession plus the pocket depth. So we will write plus 3. Plus 3, this indicates that the recession here is 3 millimeters. So that the attachment loss is 2 plus 3. 2 plus 3. That will different in the case of enlargement. In the case of enlargement, here we have a short clinical crown and we will have a great amount of the free gingiva. So it is different. Just like this case, this is the gingival margin. When we insert here the periodontal pocket depth, it will get the pocket depth by the pink line. And this is the pocket base. And also this is the CEG. If here we measure the periodontal pocket depth, it will be more than 3 millimeters. So you will consider it as a periodontitis? No, because the pocket depth is all above the CEG. So here the pocket is the same as an enlargement, so there is no attachment loss. The attachment loss is the determination or the difference between the gingivitis and the periodontitis. Here an interesting case. because here the pocket depth is not at the same of the CEJ. This is the pocket depth, this is the gingival margin, and this is the CEJ, and this is the pocket depth in this line, the amount of enlargement, and this is the attachment loss. So when we have a pocket 8 millimeters and the enlargement is 6 millimeters, so the attachment loss here is 2 millimeters, and this is diagnosed as periodontal. When we draw the gingival enlargement, we will draw the real gingival margin, draw it above the CEJ like this. Here, when we start to measure the periodontal pocket depth, it will be more than the normal because we have a gingival enlargement here. Okay, so it is will be, for example, 6. This, for example, at the middle 5. For example, at the middle 4. This is, for example, at the easier 7. But here we have a 7 millimeter pocket, yes, but it's not the real pocket. This is called pseudo pocket because we have amount of gingival enlargement by 3. So we will write -3 to know the attachment loss here. So here's the attachment loss here is 7 minus 3 equals 4. So the logic question here, how we can know the area or the position of the CEJ when the gingival enlargement is present. It is an easy procedure. You will insert the tip of your explorer, just the tip of your explorer, and try to sense the drop between the enamel and the cementum. Here is the amount, or here is the position of the CEJ. In the same paper, the radiographic finding, when you have an X-ray, you will detect the bone loss if it is horizontal bone loss and if it is angular bone loss. And writes its site. The horizontal bone loss, how do you know it is horizontal or angular? At the radiograph, we will detect the CEJ of the tooth and the CEJ of the neighboring tooth. And we will draw a line between the CEJ of the tooth and CEJ of the neighboring tooth. And when this line is parallel to the crest of the ridge, it is, or the interdental bone is a horizontal bone loss. If it form an angle, so it is an angular bone loss. Second one, the furcation involvement that we draw a star in this. We draw a star here if it is present. We draw a star at the furcation area. Furcation have grades. Grade 1, incipient bone loss and not seen in the radiograph. Grade 2, also more advanced bone loss but seen in the radiograph. Grade 3, through and through but without attachment or without gingival soft tissue loss. Grade 4, through and through with recession. Loss of lamina dura may be crystal or overall and the periodontal ligament space become widening in the case of trauma from occlusion. You see here a case of vertical bone loss. This is the CEJ of the 6, and this is the CEJ. You can know the position of the CEJ by the difference in the radiograph between the enamel and the cementum. Okay, so here the CEJ and the CEJ here. When we draw a line like this, it will form an angle with the line of the crest. So it is an angular bone loss. But here, when we have this is CEJ and this is CEJ, when we draw a line between the CEJ here and the CEJ here, it will be parallel to the crest. So it is a horizontal bone loss. This is exploring the forcation by the periodontal probe and the Napier probe. You know the Napier probe? Napier probe, it's a probe for the forcation. This is a grade 2 forcation. You see the steepened bone loss, but may appear at the radiograph or may not appear at the radiograph, and it is not like grade 3 that throw and throw. But here the forcation is more advanced, and the Napier probe inserted through and through without soft tissue loss. But here the Napier probe inserted in the forcation area with recession or with soft tissue loss. This is the radiographic lamina dura here, and this is the periodontal ligament space that widen as the case of trauma. See, this is the normal state, and this is the widening of the periodontal ligament space. This is the loss of lamina dura here. Okay. Next page, the bleeding index. Next page is the bleeding index. Here we have 4 figures. Why 4 figures? Is visit number 1, visit number 2, visit number 3, visit number 4. First, we have to measure an index. So it is not logically to perform this test at all the papillas. We have palatal papillas, and we have buccal papillas, and we have lingual papillas, and we have labial papillas. This is called papillary bleeding index. So it's the index of the bleeding at the papillas. So it is not logical to measure all of the papillas. So if we have an inflammation at the papilla, if we have an inflammation at this area, for example, it is waste of time to get the bleeding here at the buccal and get the bleeding here at the palatal. And we finally get an index. So we have how many papillas we have? We have a midline papilla, and we have a papilla between the central and the lateral, and we have a papilla between the lateral and the canine, and we have a papilla between the canine and the 4, and between 4 and 5, and between 5 and 6, and between 6 and 7, and between 7 and 8. Papilla between 7 and 8, and it is nothing to draw the 8. So we draw just the papilla. Okay. So when we get an index, we will measure the papillary bleeding index at the left side of the patient at the buccal area, and the right side of the patient at the palatal area. And the lower we will reverse. We will measure the lingual papillary bleeding at the lingual, and here we will measure here at the buccal to get an index, to get an overview according to the patient bleeding status. So how we calculate the papillary bleeding index? Here we have 7 papillas at each quadrant. So 7 papilla, 7 here, and 7 here, 7 here, and 7 here. 7 by 4 equals 28 papillas. The papilla of the midline is not calculated because it is not important in our index and it is a common papilla. When we extract the tooth, we will minus 2 papillas because the papilla is formed of junction or contact between two teeth. So when we extract, for example, this lateral, we will lose this papilla, the mesial papilla, and we will lose the distal papilla. Except the central, we will lose 1 papilla because the midline is not calculated, and the 8 we will lose 1 papilla because there is no papilla distal, the wisdom tooth. In this box, we have the upper compartment and the lower compartment. The lower compartment will be the sum of the papillas by 28 according to the patient. But here in this case we have whole set of the papillas, so it is a 28. And the upper part, it is the bleeding index. So how we calculate the bleeding index? Bleeding index has a 5 grades. Grade number 0, it is no bleeding. So grade number 0. Grade number 1, it is a point of bleeding. Grade number 2, it is the line of bleeding. Grade number 3, it is a triangle of bleeding. Grade number 4, it is a profuse bleeding. This indicates inflammation. That is why we measure the papillary bleeding index at each visit because it is an indicator for the gingival state and indicator for the healing. So when we insert or just provocate the bleeding at this area and we found here no bleeding, so we will write here by 0 and this papilla as we see by, for example, 1, 1, 1, 1, 1, 1. There's here points of bleeding. So here is a 6, so sum here is 6. For example, the sum here also is 6, and here is 6, and here is 6. So we have 4 sixes, so 4. So it is a 26, 26 at the upper part here, or upper compartment here, 26. On 28, it will get a number. We calculated 26 on 28, it will be 0.9 or 0.9. Okay, so the papillary bleeding index here is 0.9 at the first patient. You will do scaling and planning and you get a patient a routine mouth wash. So the patient will come to you at the next visit and you will measure the papillary bleeding index as before. You will have a decrease in the papillary bleeding index because these ones will be zeros or decreased. So in the second visit, you will find the 26 number will be decreased till you be 0 on 28 equals 0. No bleeding, no inflammation. The last one or the last paper, it is your diagnosis. We have two main diseases in the periodontology is the gingivitis and our periodontitis. Gingivitis or the periodontitis. So what is the attachment between the gingivitis and periodontitis? We will return to the video of the that illustrating the difference between them. The difference between attachment between gingivitis or periodontitis is the attachment loss. If we have attachment loss, it is a periodontitis. If we don't have attachment loss, it is a gingivitis, and we have a signs of inflammation, redness, and bleeding. So we will write here at the end of this rectangular the disease, if it is gingivitis and if it is periodontitis. If we have the gingivitis or the periodontitis, affection is less than 30%, it is a localized. If we have it more than 30% of teeth, it is generalized. So we can have a localized gingivitis and localized periodontitis and generalized gingivitis or a generalized periodontitis. But we need to determine the degree according to degree of gingivitis or degree of periodontitis. The gingivitis, we have we have localized gingivitis or generalized generalized gingivitis or localized chronic gingivitis. Most of cases or chronic gingivitis, and we will determine the degree if it is mild or moderate or severe. According to the periodontitis. So here in the diagnosis, we have localized or generalized gingivitis or periodontitis. Gingivitis ordinary is a chronic gingivitis. Chronic gingivitis. We don't have acute gingivitis. We have only what is called acute gingival conditions. These acute gingival conditions will be asserted as the literatures, just like the NUG, just like the acute gingival abscess. What is the state of no attachment loss with bleeding, propping, and redness? It is a case of generalized or localized chronic gingivitis. Periodontitis, or the degree of periodontitis, is determined according to the attachment loss. The attachment loss, if it is 1 to 2, it is a mild periodontitis. If it is 3 or 4, it is a moderate periodontitis. If 5 or more, it is severe periodontitis. Okay, all of these points applied on the chronic periodontitis. We have two diseases of the periodontitis: aggressive periodontitis and the chronic periodontitis. All the grades is applied only on chronic periodontitis. So we will have a localized mild chronic periodontitis, a localized moderate chronic periodontitis, localized severe chronic periodontitis, or generalized mild chronic periodontitis, or generalized moderate chronic periodontitis, or generalized severe chronic periodontitis. But in diagnosis of the aggressive periodontitis, you remember the aggressive periodontitis, it is a type of periodontitis depend on different factors, depend on its aggressiveness, because it is the amount of calculus is not coincident with the amount of destruction, will she arc-shaped defect and affect the young age. So it is diagnosed as localized aggressive periodontitis and a generalized aggressive periodontitis. The localized aggressive periodontitis affects the central incisors and the first molar, not more than 2 teeth other than the incisors and the molar. But the generalized aggressive periodontitis affects more than 2 teeth other than incisors and the molars. Etiology. Here we have a local factors such like the plaque and the plaque affective factors. Functional factors just like the open contact and the trauma from occlusion. Systemic factors just like diabetes and smoking, if present. Risk factors just like the smoking or uncontrolled diabetes. Prognosis, it is a chapter title. You will get it in the lectures. Overall, this is overall prognosis. This is for generalized condition. Individual prognosis, if we have a localized condition, depend on several factors, just like the age, oral hygiene, the medical condition, the amount of bone loss, distribution of the disease. Factors that lead to patient problem, for example, bad oral hygiene, diabetes mellitus, malpositioning of the teeth, or genetic predisposition in the case of aggressive periodontitis. An important thing according to the etiology or the diagnosis. We can have in the diagnosis generalized chronic gingivitis with localized periodontitis. Is logically because we may have some or a greater destruction at area. For example, the lower anterior have a recession and a great periodontal pocket ditch. So we have attachment loss here. So we have periodontitis, and all or the entire mouth is affected by only gingivitis. So here we can find localized chronic periodontitis with generalized gingivitis. But we cannot find generalized gingivitis with generalized periodontitis because the periodontitis includes gingivitis. The projected treatment plan including phase 1, phase 2, phase 3, phase 4. Phase 1 including scaling and root planning in the case of periodontitis only, scaling in the case of gingivitis. Oral hygiene instructions, patient education and the motivation, extraction of hopeless teeth, restoration of carious teeth, endodontic treatment, occlusal adjustment to remove the trauma from occlusion, and re-evaluation after 1 month. Phase 2, it is a periodontal surgery. After we finish the phase 1 and re-evaluate the patient, we will do a periodontal surgery at phase 2. Phase 3, we will perform here a crown or bridge preparation, insertion of the abutment placement. Phase 4, maintenance phase, every 3 months in case of periodontitis and every 6 months in case of gingivitis. And this is the last page, treatment record form. You will write the date and the treatment render, that scaling and root planing of the upper right quadrant or the lower right quadrant or some quadrant, and your name here, and this is the stuff nature. I hope all issues is covered, and good luck. Thank you.